Hey, welcome back to another chapter from the EMT book. As you can see, chapter 30, Multisystems Trauma. And we're coming to you today from a different environment. As you may or may not see, a lovely, we call it the cave where I work. It's a bunk room that was kind of added on after the fact in the garage. So it's got lovely plywood walls in the corner, and this lovely 70s porno office paneling. Anyways, so here we go. Multisystems trauma. Excuse me. So my view on this chapter is that we already know this. We've already talked about it in airway, breathing, circulation. We've talked about it in musculoskeletal trauma. We've talked about it in cardiac. We've talked about it in respiratory. Patient assessment, right? Primary assessments, ABCs, what's going to kill them in the next minute or two, as well as secondary assessment, right? If they're a multi-trauma patient, then we need to do a head-to-toe rapid trauma exam, right? What's going to kill them in the next 2 to 5 minutes. This is simply taking all of that and kind of putting it together a little bit more, because some instructors are very A, B, C, D, E, F, right? One step at a time. And the way I teach it, though, it kind of right from the beginning, I'm kind of beating this into my students' heads. So for my students, this should just be review. If you are a student with another instructor and you're looking for help with the chapters, this might be the first time you've kind of seen it this way. So anyways, let's go through it. Excuse me. So we're going to talk about what is multisystem trauma and then how to manage that patient. So more than one serious injury, and we're going to have to define that. What do we mean by a serious injury? We're going to talk about when more than one body part or more than one system is involved, like, cardiovascular, skeletal, respiratory, okay? Teamwork is the most important thing here. Without good teamwork, your timing's going to be off, transport decisions are going to be off. So teamwork's the most important thing. So in my mind, one of the worst crews you can have are two paramedics who both think they're gods, both think they're right about everything, or they have completely different practices and they don't communicate well. I've been on those calls and it drives me insane. I would much rather work with a EMT or an EMT who has no ALS capabilities and is going to kind of look at me to run this call in that situation. I would much rather do that than to be butting heads with an EMT or a paramedic, or have two people trying to run the call at the same time. So teamwork's super important. Now, we've got several decisions to make. One, is this patient multi-trauma, right? If they are multi-trauma, then they are a high priority patient, right? They have significant injuries or potentially significant injuries. And if that is the case, then we need to limit our scene time. Now, the kind of old phrase for this is called the golden hour. And the theory behind that was that if the most significantly injured patients have 1 hour from the time of injury to the time they're on the OR table, if they want to survive, they need to be on the OR table within that 1 hour. As it turns out, a lot of the studies coming out of Iraq and Afghanistan have said the most significantly injured are usually dead within 6 minutes. Okay, and that makes sense for us too, because we get to see, well, it's a trauma code. Those are your most significantly injured. There's nothing you're going to do to help them, okay? They could have gotten blown up, run over, or tossed off their motorcycle into the operating suite in front of a surgeon. They're still going to die, okay? Those are your most significantly injured. Over the next 54 minutes, which does make up that golden hour, you are still going to lose roughly 10% of your patients. Okay, so 10% in 6 minutes, another 10% over the rest of that hour. You're gonna lose about 20% within that first hour of most significantly injured. Okay, after that, that curve tends to drop some. And what that curve does is it allows us to take that patient to the most appropriate facility. All right. We're going to talk more about that. But which hospital are we going to? What is the appropriate facility for this patient? And what is the appropriate method? You know, right now the station I'm at right now is 25 minutes from a critical access hospital and in one direction, 35 to the next one. I'm 50 minutes to a decent, bigger, non-trauma center hospital, regular ICU, good OR, they've got surgeons, and then I'm about an hour and 15 minutes from the closest level 2 trauma center. So do I spend 25 minutes going to a critical access hospital, which is then going to do very basic things, and then they have to turn around and arrange transport and transfer. So the issue with that is because of what's called EMTALA, these are treatment laws that hospitals have to go by. Once you are on their property, you belong to them. They have to get permission from the receiving hospital. They have to have a physician accept the patient. The hospital's administration, which is typically the nursing supervisor, has to say, yes, we have a bed for the patient. And then you have to get the ambulance to now transport the patient to that facility. So let's say 30 minutes, 25 to 30 minutes to this local critical access hospital with a decent ER. It could take them an hour to an hour and a half to get permission to transfer the patient. Then they could end up waiting for an ambulance or a helicopter. Or I could be at that level 2 trauma center in an hour and 15. Okay, so the most appropriate facility. Now, this Glasgow Coma Scale was not in this slide program. They mention it, right? How do we determine severity? Well, let's look at physiology. So physiology is how are they responding and reacting to that injury. So Glasgow Coma Score, less than 14. Well, I think we need to know what we're talking about as far as what a Glasgow Coma Score is. So I've added this chart. So less than 14 is considered significant enough to go to a trauma center. So when we look at eye opening, when you walk up to them, do they look at you? That's spontaneous. If their eyes are closed, do they open them to speech? If you have to pinch their trapezius, or you have to do a sternal rub to get them to open their eyes, that's pain. And if there's no response, okay, they're unresponsive. Their eyes do not open to anything. No response, that's a 1. That's verbal. You say, hey, how you doing? And he goes, oh man, my neck hurts. Okay, where are you? What's your name? My name's Kevin, and I've been in a car accident. I think I'm on 16 somewhere. Okay, great. Your time, place, person. If they don't have an answer to one of those things, then they're confused. If they're telling you things that don't make sense, that's inappropriate words. What's your name, sir? Blue. Your name's Blue? What? No. Blue. Sky. All right, inappropriate words. Incomprehensible sounds, moaning, groaning, no response. Best motor. Sir, can you point to what hurts, and he does. Great. If you touch something that hurts and he reaches for it, that's moving to the localized pain. If he flexes and pulls away, if he goes decorticate, which is both arms come in, the feet curl up, that's decorticate positioning. Decerebrate is away from, okay? And then no response at all. So 15 is conscious, alert, oriented, opening your eyes, verbalizing, following commands. Any one of those is screwed up by just a little bit. That makes you less than 14, okay? Or makes you 14. 2 things, 2 points off, less than 14, so 13 or lower, you need to go to a trauma center because your brain has been affected. I want you to think about this. Totally unresponsive. No eye opening, no verbal response, no motor response. You have a Glasgow Coma score of 3. Abraham Lincoln has been dead since 1865. He has a Glasgow Coma score right now of 3 if you dug him up. Unresponsive patients have a coma score that is the same as dead people. That's not good, okay? So just keep those things in mind. Now, I tell students it would be nice to memorize this Glasgow Coma score. We've got so many other things to, oh God. Take one of these, cut it out, laminate it, put it in your ambulance on the wall next to your radio microphone. Because when you call a trauma center with any trauma patient, they're going to say, do you have a Glasgow Coma score for us? If you don't give it to them. And then you're going to, and everybody's going to be, making fun of you and giving you crap because you didn't know. So if you start right out with, hey, and this happened to me going to Dartmouth. It was a ski injury. It was an ankle, isolated ankle. Dartmouth was the closest hospital with ortho that day. It was a 45-minute ride. And I did my report, and they came back with, do you have a Glasgow Coma score? I was like, well, yeah, he's alert, oriented, following command, so let's call him a 15, okay? But it proved a point to me. So now, if I'm going to a trauma center with any trauma, I just start out with, hey, we're in a facility with conscious alert times 3, 49-year-old male has a Glasgow score of 15, and then I do the rest of my report, okay? Hypotension, we're gonna talk a little more about blood pressures and some numbers, but generally speaking, less than 90 systolic. What if they have hypertension and they are always running 160, 170 over 90, right? You get down to normal 120 over 80, they're significantly hypotensive for them, okay? So this 90 is a ballpark figure, minimum, okay? Something to keep in mind. If you anticipate that they have any shock going on at all, and remember, shock can be compensated shock, decompensated shock, or irreversible. Irreversible, we don't know until after the fact. Compensated shock, their pulse is a little bit higher, their respiratory rate's a little bit higher, they're shunting blood away from their skin and their mesentery, which is their gut, trying to keep their blood pressure stable. So you see pale, cool, diaphoretic, a little tachycardic, a little tachypneic. That's compensated shock. Okay, boom, done, trauma center. Respiratory rates, abnormally slow or greater than 29. And we're going to see that number again in a little bit. So that was physiological. Anatomic, penetrating injuries, head, neck, torso. That makes sense, right? Head, neck, torso, lots of brain, spinal column, spinal cord, heart, lungs, great vessels. Makes sense, right? Big organs, big blood-filled organs. Extremities, so arms and legs, proximal to the elbow, proximal to the knee. So why not the entire leg? Well, think about your leg. From the knee down, your vessels are smaller. From the knee to the hip, your femoral artery is huge. Okay, same kind of thing up in your arm. Brachial arteries, brachial veins, brachial vessels, right, are huge. Okay, so you got to think about it that way. Any chest wall instability or deformity, right? Not a single rib fracture, unless, let's talk about your first and second rib. Okay, those are very small ribs high up in your chest that are around and protect great vessels, and they're very hard to break. Okay, because they're so small and compact. So fractures of first and second rib have a very high mortality rate. Okay, but instability, deformity, two or more proximal long bone fractures. So this this would be femurs and humeruses. Again, above the knees, above the elbows. You break your forearm, you fall, you trip on the ice and you just fall forward. You break your forearm, that's two bones. That's not a multiple trauma event, okay? You slip on the ice, snap your ankle. Typically, ankle fractures are tibias and fibulas, two bones, not a big deal. I mean, it hurts and it sucks and all that, but it's not a high high mechanism concern. Having a humerus and a femur, two femurs, two humeruses, very concerning. Any crushed, degloved, mangled, or pulseless extremity. So let's talk about priority for a minute, right? You can call them priorities or statuses, right? We have 1, 2, and 3. So the way I've always taught this is status 3, priority 3, is a completely stable patient. Status 1 or priority 1 is life or limb threatening. That's what this is discussing, right? Pulseless extremities. Could they lose an arm? Could they lose a leg? That's a status 1 patient. Those are fairly important body parts. A status 2 or priority 2, right? Depends on how old you are. Old guys like me, it's status. But those could go either way. You're like, I'm not sure. I don't really think they're stable, but I don't really think they're critical. But that's a 2. Okay. Any amputation above the wrist or above the ankle. Any pelvic fracture. Okay. Open and depressed skull fractures and any paralysis. Makes sense, right? So we looked at physiologic, we looked at anatomical. If there are no physiological findings, you look at anatomical. If there are no anatomical injuries, you look at the mechanism of injury. Okay? So, do I have a severe mechanism of injury? Falls. Oh man, falls are a killer because, no pun intended, falls are tough because it depends on what you read. Some literature talks about 3 times the body height or 18 feet, 3 times their body height or 20 feet. Oh, I've even seen, like in the elderly, 3 to 5 feet can be significant. Okay, so falls. How far did they fall? What did they hit on the way down? And what did they land on ultimately? Both their body parts and the surface, right? You land in mulch, right? They put mulch on playgrounds now, so if kids fall off the swing set, it's soft and cushioned. When I was a kid, the swing sets were on cement. Okay, so what are you falling on? Okay, are you falling on an outstretched hand or are you falling on your head? Intrusion, that means into a vehicle. Where you are sitting, your part of the patient compartment, if that intrusion is more than 12 inches, significant. If you look at it and go, geez, I don't know if that is that 11 or is that 13? Close enough, okay? Significant intrusion. 18 inches any place else. And all that is a measurement of force, okay? If you get ejected completely or partially from an automobile, you're in the front seat of a car and you're the driver and somebody in the back seat's dead, your car has absorbed a ton of energy. Vehicles are coming out with telemetry systems that will be able to tell us these things. Keep in mind, older adults do not compensate well for shock, right? A lot of times they're on medications. You're on a beta blocker for your blood pressure, like low pressor, metoprolol. It works by keeping your heart rate slower, like 55 to 65 is typical. it will not beat faster. You cannot crank your heart rate up to compensate. I could take a stick of dynamite, stick it in your butt, light the fuse, my heart rate would go through the ceiling. The dude on low pressure, it's going to be going 56 when it explodes, okay? So they can't compensate well. Little kids compensate super well for a short period of time, and then they fall off the cliff, okay? Certain conditions, anticoagulants. Now, one baby aspirin a day does not count for this. But if they are on things like Plavix, okay, they are on warfarin or Coumadin, they're on Lovenox, those are huge red flags, okay? I did a motorcycle accident a year and a half or 2 years ago, and this dude was on Lovenox and Eliquis, and his belly was distended, right? The dude's a trauma center. The intercept I was doing, the BLS crew or AEMT crew, they were going to bring him to my hospital, which was critical access. No, he needs a trauma center, okay? Are they pregnant? Because remember, you now have 2 patients, and mom can compensate better for herself because she has about a third to maybe a half again as much blood, but she will shut that down to the fetus to protect herself, okay? Now, managing that patient. I already mentioned that sometimes, you know, I've worked with other paramedics and we didn't click well, right? It is what it is. On the way to a scene, you need to talk it out. You need to decide who's running the call, right? And by that, who's assessing the patient and who's making the decisions, okay? If my partner is assessing this patient and making those decisions, then my job is to do what he asked me to do, get the vital signs, grab the equipment that we need to get him out of here, okay? We still need to communicate that. But that way, he's not barking something at a firefighter, go get this, and I'm not barking something at him to go get that, okay? So review it. HEMS, helicopter EMS, right? A lot of better systems do yearly, quarterly, and or monthly sim labs, right? Do scenarios, do trauma scenarios. Let everybody take a turn at running these scenarios so that your crews are good. Now, some of our private EMS, it kind of sucks because you work with somebody different every day. En route to the call, talk it over, okay? Make sure the scene is safe. Make sure you're not going to get hurt. And keep in mind that people are going to drive by your scene looking at that car and they will run you over, okay? They'll run other people over and now you got a mass casualty. So please make sure the scene is safe. Shut down the road if you think you need to. And penetrating trauma, is the scene safe? Have PD clear it. We went to a knitting needle call the other day. Somebody jumped into bed, his wife had been knitting, he landed on a 12-inch knitting needle into his thigh. He got lucky. It was at a very shallow angle and it wasn't very deep. Okay? But of the 2 responding units, I'm the only one who asked dispatch, how did this happen? Oh, he jumped into bed. Okay, PD, they still sent PD ahead of us. But my partner and the first responder, nobody really thought about it. Oh, it's just a knitting needle. Yeah, 12-inch knitting needle. Okay, so think about that. Now, we have to do our primary assessment, right? What is going to kill them in the next 1 to 2 minutes? Is it their airway? Is it their breathing? Or is it bleeding? Whichever one is going to kill them first, you need to address that, okay? Then we need to move them appropriately. If they're completely stable and you're like, oh no, I'm not too worried about it, then we take all the time we want, okay? Package them beautifully, splint every little thing. But if this dude has physiologic response to trauma, he's got anatomical injuries that are significant, he's got special issues going on, you need to go, right? It might be just you pick him up, throw him on the stretcher and leave. If you can't open his airway, if you cannot maintain his airway, you need to go, okay? Give a report to the trauma team. Now, if you're going to a trauma center, you need to tell them as soon as you think you're going to go. I mean, like I said, I'm like an hour and 15 minutes away right now. I will call them from the scene. Hey, I am on scene with a motor vehicle accident, rollover. I've got a trauma team activation for you, unresponsive 40-year-old male, multi-systems. We're still packaging. I will call you in 20 minutes. Boom, done. And I hang up. Okay. 20 minutes later, I'm going to call them back and go, hey, I got more of an update for you. This is what I got. These are the vital signs. We're still 40 minutes out. I'll call you from the General Sullivan Bridge, right? Because if I'm going to Portsmouth, I got to go over the bridge from Dover into Newington. They know what that bridge is. They know that I'm 10 minutes out when I call from there. Okay, so I'm giving them a plan. I'm giving them a time frame that they can count on. Okay, and then once you're in, one person talks, not you and your partner. No, one person talks, gives a report to the trauma surgeon typically, and the nurses together at once. Then we can start talking about how are we going to move this guy over? How, what do we have on for splints, etc. Okay. Afterwards, not afterwards, I'm sorry. You do want to analyze this afterwards to see how you can do better. But during the call, decide what you need to do based on those assessments. Okay. Don't delay transport doing things that waste time. And what I do, I look at a patient and I say, if it's broken and I can fix it, I will fix it now. Okay. Airway, right? Is the airway bad? Yes. Can I do something about it right now to make it better? Yes. Do a jaw thrust, and put an oral airway in. Cool. Then I'm going to do it. If that airway is mangled and there's blood pouring out of it and I'm just continuously suctioning, we need to go. Okay. Can I fix broken arms and legs? No. So do they have something that will kill them, right? Because I can't fix spleens, I can't fix livers, I can't fix mesenteric tears, right? I can't fix ruptured bladders. We need to go. Okay? If they have an isolated leg injury, I can't fix it, but I can make it better, we're going to do that. Okay? Now, vital signs. I'm not a fan of waiting to do vital signs, because if you don't have at least one set, you don't know what your baseline is. Okay. Now, granted, your airway is a disaster and you're doing everything you can just to try to keep his airway clear of blood. Oh, okay, yeah, that makes sense. Boom. Do I have a radial pulse? Yes or no? And we're out of here. But otherwise, we have a motorcycle accident in a parking lot. The guy's 100 yards from the phone pole he hit, and his femur's sticking out, and he's not following commands. I need a set of vital signs while we package him, okay? Because 10 minutes from now, once we're in the ambulance, his vitals could be completely different, and I won't know whether we're getting better or we're getting worse. So 99 times out of 100, I want a baseline set of vitals before we ever move him. Immediate threats to life, ABCs, right? What's going to kill him first? Treat on scene what you can. Treat en route to the hospital what you can, right? I am a huge fan of traction splinting femurs on most of my multi-trauma patients. People will say, oh, you don't have to do that. You can do that en route. The problem is that those femoral bones lie next to large vessels, right? Above the knee. And the Thomas half ring traction splint was developed during World War I by Dr. Thomas, who saw that his numbers told him that femur fractures on the battlefield had an 80% mortality rate. He developed this traction splint so that the bone ends weren't bouncing up and down coming across the battlefield, bouncing up and down going across the parking lot or the field into the ambulance and then all the way to the trauma center, right? After developing the Thomas half ring, femoral fracture mortality rates dropped to 20%, 80 to 20. You know, if we're going to practice evidence-based medicine nowadays, that's pretty good evidence. Okay, so unless there's a reason I can't, I will trash this one. And you got to remember that with these Sagers nowadays, Sagers and the Kendrick devices, it takes you literally a minute to pull traction on somebody's leg. Okay, if that 1 minute is going to be the difference between them being alive at the trauma center or not, they weren't going to live anyways. Call the hospital en route, give them the vital signs, give them updates. Okay. Now, scene treatment. Yeah, we got to stabilize C-spine. If they are a multi-trauma patient going to a trauma center, they're going to have distracting injuries. They're going to have altered mental statuses. You got to collar them. Okay. Cervical, stable, cervical motion restriction. Okay, spinal motion restriction. We got to suction the airway. We got to do airways, orals or nasals, king tubes or endotracheal tubes, eye gels. Okay, we need to bag them. All multi-trauma patients should be on artery breathers. Okay, their metabolisms are going through the roof, which means that their oxygen demand is going through the roof. They tend to get cold quick. A drop of, I think it's only 2 degrees, increases your cerebral O2 demand by something like 700%. I've got a program on this that I do on the lethal triad. I'm trying to remember these numbers off the top of my head. I'm pretty close. Okay. We absolutely need to control the bleeding. We need to control the bleeding way up here, though. Okay. Scene safety, absolutely. A's, B's, C's. Move the patient. Adapt. Be ready to adapt at all times. Now, trauma scoring. It is a numerical number, and it's based on our physiology and anatomy, okay? And it allows trauma centers to gear up for things. It also allows them to do QI after the fact. It allows them to help make treatment plans as well, okay? So we have some things that make up this revised trauma score. And we're gonna go over, we already saw the Glasgow, right? So you take the Glasgow, you take the systolic, you take the respiratory rate, and then we come up with this revised. Put this on the wall next to your Glasgow. Okay, don't sit on scene and go, don't, okay? So what's our Glasgow? 13 to 15 for trauma is considered normal, although 13 is a trauma team activation, right? So as long as their pressure's greater than 89, they get a 4. Respiratory rate between 10 and 29 gets a 4. Over 29 is bad. Less than 9 is worse, kind of. By this numbering system, they are. When respiratory rates less than 9 are typically neurological injuries, okay? Neuro injuries are very high mortality rates. But when Portsmouth Hospital did their trauma study so that they could become a level 2 center, and I got this right from their EMS coordinator who was in charge of doing all of that, they had to look at trauma patients for the previous 2 years. And what they found was that every trauma patient that died in their hospital hit their ER with a respiratory rate of 30 or greater. Every one of them, okay? So respiratory rates are a huge thing. Don't just guess at it. 8 or 10 years ago, somebody from New Hampshire EMS, I was talking to them, and they said that they had done a search on Tempsys for vital signs, and they found that something like 80% of all patients in the state of New Hampshire had a respiratory rate of 14. We're not counting them, we're just guessing. 14, that looks good. Which is why I use the number 12, so I don't, so I stand out and they don't think I'm guessing. Okay, so a little bit of review real quick, right? Our multi-system trauma, serious condition, 1, 2 or more, okay? We need to recognize this. We have, CDC has a guideline for this. This is chapter review, this chapter's over with. So the authors here are saying, well, you know, CDC has a guideline for trauma triage. Who should go to a trauma center? But they didn't include it. So I did. All right, so let's look at this. The first step, number one, this is physiology. How are they responding, right? We talked about it actually in the beginning. We just didn't put it in a chart, right? So Glasgow less than 14, pressure less than 90, and respiratory rates. Any one of these is, yes, they need to go to a trauma center, okay? Level 1 preferably. If a level 1 is not available, level 2. Okay, well, what about a level 3 or a 4, Kevin? What I was told by the surgeon who worked for the state of New Hampshire, who was doing this 5 or 6 years ago, was if you can go to a level 2 trauma center, you take them there. Your level 3s are backup. Okay, a 2 has the same capabilities as a level 1. Huh? Yeah, so their requirements for having the different surgeons, the different specialists, etc., are the same as a level 1. The difference is numbers. So level 1s, I think, need something like 1,000 activations a year, whereas a level 2 only needs 100. Okay, so a level 1 should, in theory, have more experience with this, but a lot of level 1s call things trauma team activations that aren't called from the field because it allows them to throw that number in. Okay, so anyways, if the answer is no, excuse me, we look at anatomy, right? The penetrating injuries, the flail chest, 2 or more long bones, crushed, degloved, right? Pelvises, skulls, paralysis. If any of those are yes, you go to a trauma center. If those are no, now let's look at mechanism of injury, the falls. CDC says for adults, more than 20 feet, for kids, more than 10 feet. The intrusion, we talked about 12 and 18. Ejections, death. Oh, this one goes a little more into it. Oh, let's talk about pedestrians and bicyclists that get hit and get thrown. Basically, you get knocked off your bicycle, you've been thrown off your bike. You get actually run over or with significant impact. So if you're on a bicycle or you're walking and you get hit by somebody going more than 20 miles an hour, that's significant impact. Motorcycle crash more than 20 is significant. Wow. Well, yeah, there's no protection, right? You run into the back of a car at 25 or 30 miles an hour, your pelvis is going straight into the handlebars. Make sense? So if any of those mechanism injury, energy transfer things are yes, trauma center. If it's no, we go to special patients and other. So we go, older. Oh, I'm 55 years old. This scares me a little. Over 55, mortality rate climbs. Children should go to pediatric facilities if they can. You're on the anticoagulants we already talked about. You have, any bleeding disorders, okay? Burns without trauma, go to a burn center. Burns with trauma, go to a trauma center. Extremity injuries that are time sensitive, right? Pulseless extremities. You're on dialysis. More than 20 weeks pregnant. And then I love this last line. Physiology was okay. Their vital signs are all right. Anatomically, I don't really see anything that I can put my finger on. Mechanism of injury is, they're 30 years old. They're not on blood thinners. They don't have any burn. But you know what? There's just something about this I don't like. Boom, provider judgment, trauma center. New Hampshire state protocols. This is the protocol, okay? The answer is no, they can go any place you want. But if any of those are maybe yes, they go to a trauma center. And then finally, I love this one, when in doubt, transport to a trauma center, okay? Your primary assessment, ABCs, what's gonna kill them in the first 1 to 2 minutes. And if you got a problem with a B, or a C, keep working on it and get the hell out of Dodge and start heading for the hospital. Things to ask yourself: potentially injured, seriously injured, potentially seriously injured. Can I take my time on scene? Do we need to get the hell out of Dodge? And where do I take my patient? And how do I take them? Okay, so let's talk about this one. I don't normally go over these, but I like this one. So patients involved in a car crash, significant intrusion to where they were sitting. They're alert, they've got pain in the ribs. this is not telling us a lot about pain in the ribs. Pulse is 96 and regular, so 60 to 100 is normal. Respirations are 30 and adequate. Well, they got pain in the ribs. Maybe they're breathing shallow, right, so that they don't aggravate that rib pain. Blood pressure 100 over 62. So the problem is with this blood pressure, this does not tell us who this patient is, right? This patient could be a 12-year-old. This patient could be an athlete. We don't have enough information on that. Pupils equal and reactive. Skin is cool and dry. Cool. But it's dry, so they're not sweaty, they're not diaphoretic. But why are they cool? Well, it doesn't tell us if it's cold out, right? Your partner says, hey, we can take this to Huggins, right? It's critical access hospital, we can take that there. And you're like, I think we should go to a trauma center. Why? Justify it. Tell me why you think they should go to a trauma center. I don't know enough about the patient for this. I do know their skin's cool. I'm worried that they're shunting blood from the skin. That's a sign of compensated shock. I know that. Portsmouth found all their dead people had a respiratory rate of 30 and above. 29 and above, CDC says goes to a trauma center. This blood pressure, if their blood pressure 20 minutes ago was 128 over 70, their blood pressure is falling. They are no longer in compensated shock. They are in decompensated shock. They go to a trauma center, okay? So that's multi-trauma. This is the EMT chapter 30. I'm going to be doing the AEMT chapter 42, which is multi-trauma also. And it's basically the same thing. It might address it a little bit differently. But if you're looking for more, that will be there for you. Anyways, thank you for your time, and join me next time.